And before we launch into our presentation and our Q&A and our fireside chat with Chris Coburn, I wanted to give a brief introduction of MedCity News in case you're not aware of who we are. So MedCity News was founded in late 2008 to cover innovation in healthcare. It is a national publication drawing nearly 2 million page views monthly. We cover biopharma, digital health, medical devices, diagnostics, as well as hospitals and payers in the context of the industry's overall transformation. We also host conferences focusing on investment, population health, precision medicine, digital health, and patient engagement. We accept contributed content through our influencers program. If you would like to write something for us, it has to be non-promotional. Please email me at aparmer@medcitynews.com. We also do podcasts. So we recently launched this during the pandemic because we feel that every business, every entity is having to pivot these days. So we've had a few very interesting conversations, and we invite you to listen to all our episodes. And again, if you have any suggestions for people who might be great to interview, please again send them my way. I wanted to thank our sponsors, JP Morgan, Unity Point Health, BioEnterprise, and TriNet. Without their support, obviously, such an event would not be possible. This year, we wanted to include a special presentation from JP Morgan, and we had a chance to chat with Pamela Alsworth, Managing Director and Head of VC Coverage at JP Morgan. And that interview and that presentation is available on MedCity News. So I encourage you all to go take a look at it and listen to some of the advice that she's providing startups on how they can survive the pandemic. And now I wanted to talk about what we are going to discuss today. Of course, everything is about how we are meeting the moment. We're meeting the crisis that is COVID-19, that is the pandemic that is ravaging our country as well as other countries around the world. I wanted to introduce our opening speaker, Chris Coburn. He's the Chief Innovation Officer with Mass General Brigham. The institution, formerly called Partners Healthcare, is the nation's largest academic research enterprise with over $13 billion in annual revenue, 1.5 million patient visits, and 1.8 billion in research expenditures. It also has a managed care organization, outpatient facilities, and community hospitals. Chris leads a team of more than 125, and his unit's business development responsibilities include investing, company creation, international consulting, innovation management, industry collaborations, and licensing. So Chris is going to begin with a presentation, and then we're going to open it up for Q&A. The chat is disabled at this time, but as soon as he's done presenting and giving us a walkthrough of how his institution responded, we will open up the chat. So without further ado, Chris, please take it away.
Renati, thanks so much. Just confirming, is my screen should be up now?
Yes, we see it.
Great. All right, thank you. You're very kind to introduce me, and I just want to acknowledge among our team members is my colleague Tracy Doyle, who's on the line with me now, and who's done a lot of the work to pull this presentation together. As you said in the introduction, we're one of the largest healthcare systems in the U.S. Importantly, nearly $2 billion a year in research, and about 6,000, slightly more than 6,000 of our faculty are appointed at Harvard Medical School. We're the largest element of the entire Harvard community. I think importantly, though, is where we sit in Boston, our ability to access the capabilities that so characterize the community, and how that helps us drive care and innovate in a period as like the one we're in now, dominated by response to the virus. So, in terms of the view of the general public, the virus hit hard in our part of the country around the middle of March. I think it's important to note that the teams, hundreds of people on our end who were preparing for that, were at that for probably 8 weeks nonstop prior. So while most of the folks in New England were experiencing it for the first time and the hardships that came with COVID in around March 15th, our teams had been working literally around the clock for 8 full weeks. And in my view, we're already at a point of high organization, but great personal sacrifice when it occurred. So several things when we think about kind of the innovation response. First is what was going on in the environment. Well, of course, elected procedures for us and every other caregiver in our region ceased. So that meant some of our top clinical leadership was no longer carrying out what would typically dominate their day. And in the same way, laboratory research also was on a full stop, with the exception of technology related to COVID-19. So that meant that a lot of very talented people, a large number of Harvard-appointed faculty, then were available to think about and contemplate how to optimize the response to the virus from a technology dimension. So among the steps that occurred within our system was the organization of a COVID innovation-focused initiative that wound up drawing in several thousand people, not just our own faculty, but innovators from systems around the US and overseas who wanted to contribute in multiple categories. You can see there the way that we had organized it. Initially, given the PPE situation, the device need got the most focus, whether it was on materials to be worn by providers or looking at designs of machines like ventilators. So this is just a quick snapshot to capture some of the device-related work. And I want to stress we had 2 folks appointed in pathology leading this overall from MGH, Dr. Gary Tierney, a pathologist by training, also MIT PhD, and then Dr. David Walt, appointed in pathology, at Brigham, one of the co-founders of Luna, and also very active in the VCINS. So by definition, this meant more than just our own folks, quite a bit of activity with MIT, among others. One of the early wins in that area, from our standpoint, was our collaboration with Battelle. And folks may know about Battelle. It's a multi-billion-dollar technology research and management organization based in Columbus, Ohio, with facilities around the US. They do a lot of work for the US federal government, mostly Department of Energy, but also defense. They, for instance, the lead contractor on chem and biological defense. So early, like if I remember right, it was the 3rd week in March, we had reached out to them. We heard that they had developed a decontamination system that relied on work that they had done previously on the SARS epidemic. And in doing that, they had speculated that the use of VHP, vapor hydrogen peroxide, could decontaminate to a sufficient level PPE. And that's exactly the system that they developed. We were the 3rd site for them to deploy after Columbus and in New York. We were the first site outside of Ohio to be operational. I should have said New York and the state of Washington were the first 2 outside of Columbus, but we were the first besides their home base that actually had a functioning system, and a real tribute to our decontamination team, led by one of our great innovators, Orhun Murtugla. Orhun, a incredibly successful MIT-trained orthopedic innovator. Surface coatings has been his area of focus, but more recently he's been working on antimicrobial characteristics for orthopedic implants. So consequently, he brought a lot of knowledge and insight to that. And then in parallel to Orhun, we're lucky enough to have on our team the former head of supply chain from Boston Scientific, a guy who spent about a decade there during the fastest growing period of BSC's early evolution. And then also he had run operations for a big venture-backed company. So anyways, the combination of Phil and Orhun, from our standpoint, gave us a level of expertise that I think is not often associated with, would not normally be associated with an academic medical center in terms of a logistically challenging implementation of a system real time that had to draw in these garments or these masks from several dozen sites within our system, but then also all over New England, and then be decontaminated. So suffice to say, that system is still functioning splendidly today. Several 100,000 masks have been decontaminated. My impression is of the 60 sites that Patel is now in around the country, at least until 2 or 3 weeks ago, we were the most active of those sites. So now shifting now, the engine of discovery, despite the fact of so many of our faculty being home, still proceeded in so many different ways. So we had 61 COVID-related inventions, and you see some of them here. There's more on the next page that our faculty continued to pursue, and even to this day. And then on the clinical trial side, while there was a large decline in traditional trial activity, it was made up by a virtually equivalent amount of COVID-related work. And I know there's a big public announcement coming on one trial that will be led within our system. So just to give background to the audience, there was essentially a fundamental change, obviously, for us and every organization in our region during that period. But nonetheless, the basic fundamentals of discovery, translating that to use, and then thinking about regulatory approval, all stayed in place. And so consequently, these inventions and innovations pursued, I don't have a slide on it, but we did a large number of follow-on industrial collaborations and licenses of these technologies. And again, that continues. I think, everyone's assumption is that we almost certainly have to plan on some increase of the spread of the virus in the fall, and realistically not anticipating any fundamental change until late in the fall or early next year relative to testing technology or vaccines. So now switching over, at least in our back and forth with Runhadi and the host, we thought an area that would give probably the best insight into how this challenge of the pandemic bred an unprecedented response for us, and again, other systems as well. And so we thought focusing on our digital response, again, the quick summary I did a moment ago in these other categories, but going somewhat deep on digital would help to communicate, I think, some of these important points. So first of all, thankfully, a year ago, we had launched, slightly more than a year ago, a new enterprise data and digital initiative. This is a large board-approved investment to enhance enhance delivery of care with digital tools, but also how we were organized to do it. So a real blessing from our standpoint, because the implementation of EDDH, the preparation for that, the self-assessment, the creation of teams, all that occurred as a prelude to the arrival of the virus in the US and ultimately in Massachusetts. So, so a great blessing, and a very important part of that was the recruitment a couple of years ago of a chief digital health officer, Dr. Alistair Erskine, came to us from Geisinger and had also been active overseas. So a real leader with a vision for what needed to be done. So when you think about COVID and our system and innovation, you know, think about the breadth of digital responses. So whether it was you know, organizing in category or the synergy among categories because we were already in place. So again, the teams, the resources had already been made available, and I think allowed us to advance in a way that we would not otherwise have been able to. So we were one of the last big systems to commit to one of the primary vendors in terms of EHR. We're an Epic customer. You know, we announced that we committed $1.2 billion to that. And so consequently, Epic for us, and I think for many, many providers around the US, was the backbone of the digital response. But you know, just think about how dynamic the period was in that, first of all, exactly what the challenge was still being discerned, but then the guidance of what the response was to be, whether it was federal or state or even payers, was shifting real time. And so our teams had to adapt the systems, the electronic and human systems that you know, constitute the delivery of care. And as you can see on the slide, almost 3,000 build changes occurred during about a 6-week period. So to me, a breathtaking achievement that really enabled things that would not otherwise have been possible. So whether it was inpatient, ambulatory, so you know, the engagement of the patients in a community setting, capturing the right information, integrating it, assessing it, working on real-time information sharing rather than just a daily snapshot, building out special units, the physical aspects of that. How we were going to get paid was an important thing to consider, especially when elective procedures had been stopped, and we, like almost every big system, have now lost many hundreds of millions of dollars, and the model is up to $2 billion for the year. Patient experience in this setting, a crucial element. And then finally, we, like in New York City and a few other places, built a field hospital, in this case, like New York, in the principal convention center in the city. And so, again, from my standpoint, just just stunning achievement. The physical aspects, getting all those beds in there, getting the people deployed, but also the required information technology to run a brand new hospital in a brand new site. So really remarkable. So, a lot of the discussion in the, over these many months now has been virtual care. And you see for us, that came down into 4 priority areas. The level, I think I have this number here. The level of virtual visits for us, I believe, went from maybe 1,500 over that period of time to 250 a year before, to 250,000 during that period. So just shocking how much of a change it was. But also, what could you do with virtual care? I think one of the learnings that the clinical team had was from a COVID diagnostic standpoint, it wasn't as revealing as it might have been, since so many other things were involved in that. But in the management of the patients, particularly after discharge or keeping them out of the hospital, it became a very, very important tool. So again, real time. Now, the thing to stress, particularly given that this is an investment conference, was the torrent of potential solutions that were coming at these teams. I think among themselves, they referred to these occasionally as an epidemic, given that there was such a huge selection and the need to decide when you were going to use something from the outside. And again, big academic centers are rarely known to move fast as it relates to digital acquisition. So for us to be able to organize, make decisions, and implement in a matter of days was, to me, among the greatest achievements that were that our digital teams accomplished. So,
Chris, may I interrupt you for a moment, since you allowed me to interrupt you right at the beginning? When you talk about virtual care, one of the things that we are trying to look at is virtual care needs to mean something more than just video visits. So I'm wondering if you can sort of expand upon that point, where we saw everything going from in-person visits to video visits or telephone, but that's not virtual care. So how do you define and move forward this adoption of technology that you've done?
Yeah, great question. I actually have a couple slides on what's coming, but we think it's going to settle in long-term, once we're through this period, at maybe 30% of the care that's provided will be done electronically. Things to talk about is the unequal distribution of technology. For us, I think 80% of the patient interface was done on a video basis, but a large percentage, I think it was 20%, was provided by phone. And that was because that's what the patients had and needed. So again, this question of how we define virtual care and how it fits into the overall delivery, I think is one that's still showing itself. So, but let me get the slides on the future. I'm having a little bit of an issue with my screen here. Screen is still okay for the viewers, I hope?
You probably want to go back into that view slideshow so we get to see our full screen.
Okay, hold on. So you're not getting the full screen, right?
This is fine, it works.
Hold on. Better?
Much better. Thank you.
Okay, thanks.
And I won't interrupt you anymore.
No, that's all right. So, so again, just to recapitulate, all this is happening at the same time. There really isn't a playbook. So, the teams had to organize themselves in key areas. And for us, for these 4 primary areas, and then you see in the second column how that broke down. So just, among other things, we had to switch vendors. The vendor that had been in place for a while, I think for about a year, was overwhelmed by the market dynamics and was unable to support us and I imagine others. And so then our teams had to implement Zoom, and then of course integrate it into a HIPAA compliant Epic platform. So that was a big element. And then, for inpatients, I know this has been profiled at other hospitals, but it was a very important point of the strategy for us, which was basically to have an iPad in every patient's room that was affixed to a pole that could hold it and be visible, and essentially become a portal between the patient and caregivers, and then importantly their family. So allowing for monitoring that would have otherwise been done in person to be accomplished in a highly contagious environment like the one that was experienced. On the data analysis side, lots to be done, dashboards to be created, discerning the key and ranking the key performance metrics. As I said a moment ago, shifting from what otherwise might have been a daily or maybe even a weekly snapshot to determining what had to be real time and how would that then be extracted and presented became a very important element of our response. Tools for employees, self-assessment relative to their own health, and then also tools for the traditional chronic illness patient management, again, which has to continue to occur in an environment like this. Of course, the implementation of COVID-facing pathology and outcomes assessment, and then the computational requirements. Again, think about how big we are, how many patients we're talking about, were really remarkable, and to be able to grind that much data was really crucial. So just a couple last slides here on the future. So I think for the whole medical community, obviously an epiphany was reached on digital, and obviously not just among those who had been advocates or even apostles for evangelists for the technology, but an acceptance across the board, whether it's providers, payers, or patients, that this is a tool that can provide meaningful results that at times will be less costly and more convenient for all involved. So that, for sure that's here, obviously. How much it will is debatable, but from our standpoint, from our digital leadership side, we're likely talking about something around 30%. Obviously digital assets can be modified in response to what this crisis or a future crisis much more quickly than, a physical facility can be reconfigured. And then not knowing what the future will bring, practices that were optimized over the last couple months, which may now have been cycled down or even concluded, are now basically fully templated and ready to be redeployed on very short notice if we encounter a future surge. And then from a policy standpoint, I would assume virtually everyone in this call is familiar that so much what occurred over the last few months was temporary approvals, whether it's on the financial or regulatory side. And when a crisis is no longer defined, most of those will revert. So where that is going to end up is really key. And then, this question about traditional geographic boundaries in a digital world is an important one. So, the ability for caregivers to support patients in a different geography will need some additional attention, and then HIPAA-related issues that may need to be dealt with on a short or long-term basis. Finally, last slide. Kind of what's the lessons learned from a big system standpoint. The ability to adapt and in a period where you cannot be sure of what is going to occur the next day relative to patient volume, to understanding the disease. And I think from my standpoint, one of the great heroic aspects of the response here and elsewhere, the US and around the world, was just how quickly caregivers adapted, and how often cultural, longstanding cultural, strongly held perspectives were yielded or even totally abandoned in a period. And, again, to the credit of all involved. So the ability to adapt, the ability to work together in new ways, whether that's outside of a defined environment, whether it's among disciplines, among different categories of technology, all that was key. If I didn't stress it, I will now. A new version of care was basically invented again, for us and around the world, in terms of a robust virtual assessment and patient management environment, and everything that had to go with it. And so that was so key. The data environment I mentioned a couple times. For us, thankfully, we had a head start on it, given this approval last year of EDDH, but the ability to design for these outcomes. And then, never forgetting that this is an unprecedented time to learn, whether it's learning about the disease or patient needs, or just learning about how to optimally deliver care. And that certainly was a big part of the approach of our team. So why don't I conclude there, and happy to take questions or share perspectives.
Great, Chris, thank you so much for sharing that in-depth presentation. We're enabling chat right now, and just as soon as people start asking questions, I will send them and read them out to you, Chris. But while they are typing their questions and gathering their thoughts, I thought to ask you something regarding what you said about how quickly you were able to invest in certain new technologies. I'm just wondering whether you can give us a sense of the criteria. So in a crunch time, you're dealing with a public health crisis, you have to, assuming you have to set aside some of the normal criteria for investing and deploying. So how did that change during the pandemic?
Yeah, well, of course, responding to any crisis, there's a financial dimension. But I would say, again, from my perspective, the most important criteria was clinical or workflow fit. Could it be deployed quickly and reliably in a dynamic environment? So again, costs certainly mattered, still do, but the crisis, the need to act, and get a high quality product that is going to perform reliably in a regulated environment was so key. And smart people come at different different answers when the many different variables are involved. But in the end, in a crisis like this, it meant that they had to come to consensus in an environment that, academia, when I arrived in Boston, someone told me, you have to get used to 16-1 as a tie vote. And, that all had to be overcome. So I would say, again, the fit, the reliability, the safety of the technology trumped all other criteria.
So there's one question from the audience, which goes like this. Could you share any implemented innovations in allowing the use of patient-generated data from outside the system?
So how we're accessing data from the patient community as it relates to COVID care?
I'm going to assume that they're talking about patient-generated data, I'm guessing from wearables or some connected device that they might be using.
Good question. Certainly, obviously, we're very active in population health management. So data acquisition from those kind of environments are part of the program. I'm personally not familiar, and it could have happened in terms of the COVID response, but just to kind of drill into that point, one of the hardest city areas for folks that know Boston, was very close geographically to our biggest hospital, and it was a difficult environment, and now much better, but very challenging. And so one of our lead pathologists went out and personally, in the height of the initial surge, took over 1,000 blood samples from the residents of that neighborhood. And, that information became very crucial in designing responses. So, I think acquired every way possible. And I can check if whoever asked that question wants a follow-up, I can get
Sure.
a specific answer.
Sure. So we have the most important question, I think, from the audience. What is your preferred contact method for evaluating opportunities? Do you take cold emails and respond to them, or does it go to your assistant?
Yeah, well, I probably should have said, as it relates to our shop, and since so much of this presentation was on digital, we just announced our first ever digital fund, AI and digital fund, we call it ADIF, which is a $30 million commitment, which is small. We also have about $200 million under management in our historic fund, which we will be growing rather significantly in the next several months. But so we created this digital fund, and so this will allow us to participate in early stage companies, as we did with a company called Health Catalyst that I'm sure a lot of folks know, both as a co-developer and as an owner. So, but we also think that having this as a structured element will more directly align us with early stage companies as they offer solutions. So right now, my office is tracking about 100 emerging companies in anticipation of our first round of investments. So I would say email, you can email me, the lead person in our office. His name is Mike Freni, F-R-E-N-I, and the head of our digital fund, her name is Gay Bach. Some of you might know her from the Boston venture community before she got here. And I see several of my old friends, including Matt Herman and Chris Little, have responded, and I just say hi to them.
And Chris, you are going to give MedCity News first dibs when you make that first announcement from your investment fund.
Of course. And it's a complicated time. The investment fund had been approved last fall, and so we're working our way through. But I think we are all aligned on the need and the opportunity to become more active from an ownership standpoint in the digital world.
Okay, another question. What changes do health systems need to implement to ensure they survive in a post-pandemic world, if we can even imagine a post-pandemic world today?
Yeah, and I saw who asked that question. That's a great question. Thank you, Matt. It is something any of us who work for providers are all reflecting on. It is a lot of questions I think have been raised, some of them answered, about basic care models. So, how are we going to use digital technology? How do we define ourselves in terms of what's our value add from in a ambulatory care environment versus what so much of Boston is recognized for in terms of quaternary and tertiary care. So, I think we all need to settle on that and do it quickly. I know our leadership, going back to May even, was anxious to get back to delivering in the traditional ways, in the sense that so many lessons were learned, so things were accelerated. So many of the challenges that folks might associate with large organizations were overcome. So, as difficult as this period is, I'm personally optimistic. Care will be better, and smart systems will be better at it in the future. But we have a ways to go. There's no, still a lot of challenges out there. But I think our leadership and the line teams are as passionate as they ever have been, but now have new tools, new insights, and are rearing to implement them.
One question was about MIT and how you were able to mobilize MIT so quickly, and what was some of their biggest contributions?
Well, so for people who know Boston, so of our core AMCs, Brigham, McLean, Mass General, and Mass Sinai, two of those four, if you were really good with your driver, you could probably hit a golf ball from there to MIT, at least MIT-owned property. So, we're as interdigitated as we could be, but also just culturally, there's so many programs that involve faculty from MIT. Some of our best-known faculty are co-appointed at MIT and at our hospitals, whether it's Elazar Edelman, who's a cardiologist at Brigham, who's one of the best-known innovators, device innovators at MIT. So many folks have shared that legacy. So to me, no surprise that there was so much collaboration between us and them.
And I had a question myself surrounding data security. We've read recently about, Russian hackers trying to access, data from research institutions developing vaccines. So when you're dealing with such a deluge of data, you're collaborating in an unprecedented fashion. How do you ensure data security? How much of a headache was that for you?
Well, it gets talked about generally, but, among the day in and day out top priority items, that is right as high as it can go. And even though he's not in healthcare, I think of that Jamie Dimon quote, my head of data security is the one person who doesn't have a budget in the organization. And, it's kind of the same way for us. It's so important and so ever present. So, all the changes have to occur in that environment. You can't get it wrong, yet you have active adversaries. I don't know how many people have ever, when I was at Cleveland Clinic, but also here, you can see that map that the data security people have that shows you where you're under attack from at that moment or that day or that week. It's eye-popping. So anyways, it is, I couldn't imagine a higher priority than data security, but it's a job that's never done.
I'm just wondering if you could be a little more specific on some of the investments you've made at this time in terms of deploying technology. Were there, I would love it if you could name some companies, but if you can't, are there broad areas where there are real opportunities for technology to do well? And I'm talking beyond just virtual care.
Well, yeah, from an investment standpoint, so I didn't have a chance to scroll through all the names, but I know a few folks work for hospital systems, and I think they would agree with me. If you're looking to be an innovator or an investor in digital health or operational related technology, margin is the area to go after. Revenue increases in this environment, sure, they might happen, but from a digital standpoint, if you have a tool that can help a provider be more efficient to possibly disintermediate third parties that that where the hospital or system might be able to do things themselves, that's still an area of need. Of course, on the virtual standpoint, one would expect technology will improve, where the solution, just the technological breadth of what is being offered. So those will all iterate, whether it's the current incumbents or others. So you would expect very soon the digital platform that hospitals exist on will have a degree of sophistication that was only dreamed about 2 or 3 years ago.
I just wanted to mention as a general note to the audience, Tracy from Mass General Brigham has just posted in the chat the email addresses of all the people who will take your pitches if you have some interesting technology to share with Mass General Brigham. Another question, Chris, on post-pandemic vision, how does international cooperation and collaboration look like in a post-pandemic world?
Well, thanks for asking that question. And the international consulting arm of the system is under our umbrella in our office. So we do think about that a lot. I think from that standpoint, the access of talent in hospitals in the US will be more efficiently achieved in the future. So, whether you're dialing in for a second opinion or you want to know, how one of the Ascension hospitals handles a workflow or Mayo or us, that's going to be a fairly direct exchange. The flip side is, I think, the idea, at least in the short term, of patients getting on a plane and deriving their care, in a big city in the U.S., there has been, and there will continue to be a large drop on that. So there'll be the auxiliary care, let's call it, that might be provided for those patients, or all the telemedicine tools that are being deployed here will, of course, work in an international environment by and large. So yes, that'll grow, but someone coming overseas, at least in the short term, is going to be significantly diminished.
There's a very interesting question on patient response. Can you mention what the patient response was like to all the technological swift changes that you made? Did they adapt as easily? For instance, did patients understand the system? How much education was required? Who educated them? Was it nurses, doctors, or IT tech people?
Yeah, I think the mindset which so admirably characterized the situation in New England and elsewhere was, we're all in this together. And so I think patients were more resourceful, more flexible, less, less stuck in whatever, and I shouldn't say stuck, but less, more willing just to adapt their own approach. And so that occurred. And we all figured out things. We all figured out how to, order food from a restaurant and not sit in there and down a long list. And one of them was how to get care. So again, a lot of traditional categories dropped off. Some of them almost stopped. But in terms of COVID related, and then ultimately what grew out of it, patients are very resourceful, insightful, and at least as I understand it, remarkably goodwill about deriving the care in a new way. And, a lot of enthusiasm. Once they saw what could be done, many patients prefer an environment where they're at home and they're not required to be in a car to park or public transportation, whatever it takes. So there's a lot of enthusiasm for this new environment. And like I said, we're modeling that it will go back to, I shouldn't say go back, it'll settle at about 30%. But, for many weeks, it was way more than a majority of care visits for us.
Here's a question regarding behavioral health. Have you considered investments in behavioral health? And if so, what are your criteria? And where does mental health fit into your priority for both patients and caregivers?
Thank you for that question. Ironic that you asked that, because I was in a meeting with what we call our Behavioral Health Commercialization Council, which is psychiatric leaders from our 3 big hospitals, to talk about this exact, among points, this one. So yeah, we are doing a lot in digital behavioral health. We have a big collaboration with Telefonica as an example, another company, Alpha Health, which is tied to them. And then some of the really well-known examples related to pharma. We've worked with any number of those companies. So we see it as a significant and growing area relative to our own fund. And Tracy was nice enough, Tracy Doyle, to send the link for Gay Bach and Mike Frenny. We certainly expect, if there's a strategic priority in growing the commercial side of our behavioral health community, it's going to be on digital technology. So yeah, absolutely. And I just one quick footnote, just on that point about our collaboration with MIT. For us, behavioral health can also trend over into other areas like, understanding consciousness. And Emory Brown is a very famous anesthesiologist appointed at MGH, but also equally known as a faculty member at MIT, MD, PhD. So just as an example about how these things will emerge in many categories.
Chris, you just mentioned the AI fund and the 30 million in gunpowder that you have in terms of investments. Have you made any commitments to ensure that there is a diversity in the types of companies that get funded? So there are women-owned, minority-owned startups that you support.
Yeah, that great question again. So hard to state a higher strategic priority for our system right now than diversity, gender, race. For us, for our office on the gender side, we have a project ongoing. Tracy's part of this team where we're teaming with a young professor from Harvard Business School, Katie Kaufman, to really come at this question of why is the participation in innovation so skewed by white males? And we're assessing our own activity, our own inclination for discovery and application and commercial collaboration, but we're also looking outside. And Katie's work, if folks haven't seen it, is really terrific. She has a paper currently that's either recently been in or will be in PNAS studying, and this empirical side to business analysis is so welcome. So she and a co-author studied SAT taking among male and females, and one of the things she discerned was, and this is, they got access to results for the nation of Chile, which over several years were millions of records, that showed that if you framed the question with a penalty for guessing wrong, female test takers were less likely to answer that question, and consequently disadvantaged in the overall scoring and ranking associated with it. If you took out that criteria, so just simply said no penalty for guessing, results normalized, particularly in the areas that would be more often associated with the male gender in terms of physical sciences, as an example. So take a look at her work. It's Katie Kaufman with a C. We're going to be doing a lot more relative to the companies. I think we're a good start with Gay Bach as the leader of the fund. But if you look at the performance of our historic fund on that issue of gender, we call it the Partners Innovation Fund. We're now shifting the name to Mass General Brigham Ventures. We're like 3x over, or maybe it's more actually. I think about 20% of our CEOs of our portfolio companies are female, and in the life science community, that dwarfs what would be the industry standard. So we're in a good place, but we're very strongly committed, and we all can do better, and we need to be smart about it. And from our standpoint, access new perspectives of the kind someone like Katie Kaufman's working at HBS.
So we're over an hour, but I would like to conclude with one public health question. Chris, do you think the nation and Mass General Brigham would have benefited if we had a coherent federal response?
So I won't be addressing that question. I would say that the work of Governor Baker in Massachusetts was terrific and really exemplary, not just from an elected official standpoint, but from a management of a large and complex challenge. And Governor Baker, some of the folks here may know, prior to being elected governor, was the CEO of one of the payers, Harvard Pilgrim, here in Massachusetts. So uniquely equipped, but you know, having grown up in Ohio and worked at Cleveland Clinic, I think the work of Governor DeWine has really been terrific, and so many other governors. So, you know, we need to do more as a country. We need to be more organized. We need to be more collaborative. We need to be more insightful of what the drivers of the disease are, because it's not going to get better on its own. It's only through our collective action, coordinated collective action, that it will be put into submission in the way it has been in so many other nations around the world.
Well, I'll let you off easy by praising the governors. I think most of us agree that the governors have done an excellent job. But again, thank you so much, Chris, for doing this and for giving us insight as to how you responded. It's a big chunk of your time, so I appreciate it.